12. Thank you. I'm Dr. Jill Rockbeisel, the chair of the department, and I want to welcome you to our grand rounds. I would like to welcome all faculty, staff, and trainees that have joined us for our twice a month grand rounds. And I also have Dr. Woodbury, who would like to welcome a special group of attendees.
Hey guys, I'm Meg Woodbury. I work on the Psych CL service for kiddos, and I work with Dr. Crawford really closely on a lot of our cases. I wanted to thank the pediatric department, who I believe most of them are joining via Zoom, including applicants for the pediatric residency. Thank you guys for making time today. I also see psych occupational therapy is here, nutrition is here, and so I just really appreciate you guys coming in for a multidisciplinary perspective, as the care for kids with eating disorders truly requires a village. So thank you.
Great. Thank you, Meg. Before we get started, just a couple housekeeping. All of those of you on remote, please make sure that you mute your mics. We are going to have Dr. Crawford do his presentation, and then we'll take questions at the end. So if you could jot your questions down, or you can stick them in the chat if you like, for those in remote, and we'll take questions at the end. Very exciting. We're also continuing to work on CEUs. We get the CMEs, but we're working on CEUs for all disciplines. So I believe that has been put into play for today, but I'll clarify that. And I also want to make two other very, very important announcements that are very exciting for the Department of Psychiatry. I want to remind folks of two dates. We have Dr. Deanna Kelly's investiture as the Dr. William and Carol Carpenter Endowed Professor for Mental Illness Research. And that investiture is on November 28th. It's a Tuesday. The actual ceremony starts at 4:30. I go to these investitures all the time, and the attendance at them waxes and wanes. We have a very large department, a very proud department of our MPRC and Dr. Carpenter and Dr. Kelly. And I would like this investiture to be really, I would like us to show up in this gangbusters. So I want to just tell you that they're really fun. The actual formal ceremony starts at 4:30, but there's drinks and a little bit of social starting at 4. And then 4:30, we all sit down, and there's about a half-hour program, followed by hearty hors d'oeuvres and more drinks, and an opportunity to mingle. So I just would like everyone to, you should be receiving your invitations to the investiture today or tomorrow. They're sending them out in batches now, and everyone is welcome. So please plan to attend and celebrate Dr. Kelly and Dr. Carpenter. The other announcement that I wanted to remind folks of is that our bi-monthly faculty meeting was bumped from I think the 9th of November to the 30th of November, so the Thursday after Thanksgiving. Really, really important meeting, and I want to encourage all faculty to attend. It will be in person, and we have a reserved room. A couple things that we need to talk about as a group. You know, we have great partnerships and collaboration among ourselves. We need to talk about how we monitor our own successes and how do we collect data in reflecting that. And I think we can do a better job of that, and I want us as a faculty to come together on that. We also need to talk about unfunded, unsponsored research, and have a systematic way in the department to provide support for folks, to provide and a process so that we are aware of everything that's going on and that we're in compliance. So again, with the intention of supporting new investigators, established investigators, but anyone that has unsponsored or unfunded research, we're going to be talking about that too. Other agenda items, but those are some of the important ones. So with that, I want to move on and introduce our guest speaker. So this is with great pleasure and honor. I am introducing our guest speaker today, Dr. Stephen Crawford. is the Regional Medical Director for the East and Midwest regions of the ERC Pathlight and Assistant Chief of Psychiatry at the University of Maryland St. Joseph Medical Center. Dr. Crawford attended the University of Maryland School of Medicine, where he then went on to complete his residency here in our own department. So he's one of us that has stayed connected throughout his entire career. He received fellowship training in eating disorders at the Center for Eating Disorders through the University of Maryland Department of Psychiatry, and has worked continuously in the field for over 30 years, primarily as the co-director of the Center for Eating Disorders. Dr. Crawford is the past president of the Maryland Psychiatric Society. He has participated in international research in eating disorder field and is widely published, including co-editing Psychiatric Clinics of North America Eating Disorders Part 1 and 2. So it is with great joy that I ask you to join me in welcoming Dr. Crawford to hear Eating Disorders an Update.
Well, thank you, Dr. Rockweisel, for that introduction. And I do want to say that I'm really happy to be able to be here today and have the opportunity to present to you on the topic of eating disorders. I really strongly feel it is a topic that unfortunately doesn't get enough airtime and focus. And so there's a lot of providers in the community that aren't trained on eating disorders and don't recognize them. And these patients are in desperate need of providers that really do understand them and are able to help them. So really happy to be here. I really appreciate the opportunity to collaborate in so many ways over the past couple of years with providers here at Maryland. Dr. Woodbury and I talk on an increasingly regular basis, it seems, on some challenging cases. And I know the child unit has had some cases as well. So really appreciate the opportunity and love the opportunity to collaborate. In getting started, we'll be talking about eating disorders and okay. So the objectives for today's talk, I'll start off just briefly reviewing diagnosing eating disorders, talking about some of the signs and symptoms, outcomes. We'll go into screening, the screening process for an eating disorder, comorbidity. We'll focus a lot on the medical complications associated with these illnesses and the management of those medical complications. And then we'll also get into some of the treatment aspects. And getting started with diagnosis. These are the eating disorders that you can find in the DSM-5. And for the purpose of today's talk, we'll be talking about the ones everybody historically knows of anorexia nervosa and bulimia nervosa, and what was introduced into the DSM-5 with binge eating disorder and avoidant restrictive food intake disorder. And we'll touch briefly on other specified eating or feeding disorder. Now, in getting started with making a diagnosis of an eating disorder, there are three primary factors you want to take into consideration. Most people, when they think of eating disorders, think about weight. It's important to realize that weight is only a required criterion in the diagnosis of one eating disorder, and that's anorexia nervosa. And so for anorexia, you need to be at a weight that's significantly below what would be expected for someone's age, height, gender, and developmental trajectory. And so the weight criterion, behaviors. Behaviors are the second factor. And like most psychiatric illnesses, there's a lingo to eating disorders. Providers use it, patients use it. They talk about binge eating, purging, they talk about restricting. And so it's really important when you're providing treatment to a patient to understand what those words mean to that particular patient. Because behavioral illness, you're trying to change behaviors, so you have to know that individual's behaviors. And I'm done. So thank you all for coming. The external display is disconnected. Hit OK.
Think we were there.
Yes, it's perfect. Okay, we're back.
No. There's a plug we were stepping, people were stepping. They told me that was really bad. All right. Yeah. Is it loose on our end?
No worries. All right, we're going to try again. All right, so with the behaviors, knowing what the patient's talking about, example is that when a patient with anorexia nervosa says they binged, it probably means something very different than when somebody with binge eating disorder says they binged. So getting those specifics is important. The cognitions, what are the thoughts associated with the illness? Well, body image is a primary factor in most eating disorders with the exception of ARFID. And so getting a sense of how the person's feeling about their body and how it ties into their sense of self-worth. The core belief for somebody with an eating disorder almost always is, I am not worthy. And so they have a sense that if they can fix their body in some way, that they will feel better about themselves and their sense of self-worth will go up. And that's the core work that's done in CBT with these patients. In addition to the self-worth, there's phobias and indifference, which really come into play in ARFID, and we'll be talking more about that. So I'm not going to spend a lot of time on the diagnostic criteria. This is anorexia nervosa. The behavior is restricting intake so that you're losing weight. Avoidant restrictive food intake disorder we'll take a little more time with. And this is the patient is also not taking in enough calories to meet their body's nutritional requirements. So they end up losing weight in general, or they end up stunting their growth. But it's not because of a body image disturbance that they're not eating. And that's the primary thing to be aware of. That a lot of times these patients are aware that they're too low in body weight, that they need to gain weight. The thing that's driving this, and this is a diagram done by Jennifer Thomas in an article in 2017, looking at the causes for ARFID. One primary cause is sensory sensitivity. So patients don't like the way food either tastes in their mouth or it feels in their mouth. So they avoid eating. Patients with autism, 15% of patients in the ASD category meet criteria for ARFID. Some studies actually say it's even significantly higher than that. The second possibility is the person just in general doesn't tune into hunger cues. They don't recognize hunger cues. They're indifferent to the thought of eating, and they can go all day without eating unless someone says, you know, it's time for dinner, we need to eat. And then they'll go ahead and eat, but otherwise it doesn't happen. Okay. Yep. Okay. All right. And then the third would be the person develops a fear of some aversive consequence. And here you have a patient who chokes on a hot dog. And then they become afraid that they're going to choke if they eat another hot dog, so they decide no more hot dogs. But then that fear starts to generalize. All fears, when you have them, will generalize if you don't treat them. So that the fear of the hot dog goes to meat in general. It then goes to other food groups. And over time, the person becomes afraid of even drinking a glass of water for fear that they'll choke. So their available food choices really, really narrows. And subsequently, there's hardly anything left for them to eat, and they end up not meeting their nutritional needs. Another example would be an anaphylaxis response. The patients that, have anaphylaxis response to shellfish, they say, okay, I can't eat shellfish ever again. Then it generalizes to fish, then to meat, and then to other food groups. Same similar process. Some patients in this category may have a fear of vomiting. So they witnessed a sibling throw up, or they had an episode of vomiting, and they become intensely afraid of vomiting. So they figure if they don't eat, they won't throw up. And that's leading to the ARFID. The fear of an aversive GI response would be patients with chronic nausea, or a patient that feels bloated after they eat. So a patient gets a sensation of bloated, they should say, okay, well, I'm going to eat less. Now, the problem with eating less is you develop what's called gastroparesis. And gastroparesis is delayed gastric emptying. When a person eats a meal, on average, food sits in your stomach for an hour, and then it goes into your intestines. Person with an eating disorder, they have delayed gastric emptying. So food sits in their stomach for prolonged periods of time. The more you restrict, the longer that time is. Have some patients that can eat dinner and wake up the next morning with undigested food in their stomach still. So that becomes very difficult for them to have the eating process, and they avoid eating. The problem with that is the less you eat, the longer the gastric delay ends up happening, so you make the problem worse and worse, and it cycles down in the wrong direction. Okay, bulimia behaviors here are binge eating and purging. Binge eating disorder is binge eating without the purging. Other specified feeding or eating disorders, this is an important category. Atypical anorexia nervosa. Say you have a patient that started at 175 pounds, they're 5'5", and they've lost weight all the way down to 125 pounds. So they've lost 50 pounds. They think they're still fat. They're driven to lose weight. They really have a distorted body image, and they're basing their sense of self-worth on how they feel about their body. They don't meet criteria for anorexia because in the books, they're not low enough in weight. And remember, anorexia has that criterion. So these people would fall into atypical anorexia nervosa. The important thing to know is these patients have all the same risk of adverse outcomes and negative consequences of not eating as people that are meeting the criteria. So they need treatment, they deserve treatment. A lot of times they end up feeling like they failed their illness because they're not successful in getting down to lower body weights. And so then there's a lot of work to do in that way. Binge eating disorder and bulimia nervosa of low frequency or limited duration is just that. The criterion is once a week. If they're doing it every other week, or 3 months is required. So if they've been doing it for 2 months, then they fall into that category. Purging disorder is if you're eating normally, but then inducing vomiting or taking laxatives or diuretics or something like that after you're eating. And night eating syndrome is getting up in the middle of the night and eating large quantities of food and not really having great recollection of it. People know what the most common cause of night eating syndrome is? Ambien. So it's an easy way to help somebody. You tell them to stop the Ambien. Okay. So when you look at this slide, who's at risk for an eating disorder? I think the stereotype everybody knows is the young girl in the middle. And unfortunately, well, I think everybody knows that that's no longer the case. People still are impacted by that stereotype and forget to ask these other populations. Everyone up there is at high risk. 1 in 4 people seeking treatment for obesity has an undisclosed eating disorder. And you really need to find out about the eating disorder if you're going to be able to help these individuals. Athletes, we always think they're extremely healthy and the epitome of health, high risk population for eating disordered behavior. This is looking at college athletes and 35% of females in the NCAA and 10% of males meet criteria for anorexia and 58% of women and 38% of men for bulimia. The number of older individuals getting admitted for eating disorders has really skyrocketed in the last 10 years, up 88%. So we're seeing more and more people from all genders, age groups. 1 in 4 people is now male, used to be 1 in 10. So the statistics have changed significantly. Black teenagers are 50% more likely to exhibit bulimic behavior than white teenagers. Hispanic people significantly more likely to have bulimic behavior than non-Hispanic peers. Despite this, people of color are half as likely to be diagnosed or to receive treatment, which is a significant problem because people are still holding on to that stereotype. We need to let that stereotype go so we can get people the help that they need. Gay men are 7 times more likely to report binge eating, 12 times more likely to report purging than heterosexual men. Okay, ARFID is a couple more thoughts about ARFID. It's generally considered to be a childhood illness, so people think of kids when they think of ARFID and don't really think of adults. But ARFID can start at any point in life, because if you remember that third category of fear of aversive consequences, you can choke as an adult and develop ARFID. So you have to remember that sometimes ARFID is important. The adults tend to show up with a GI complaint, and then they get a major GI workup, and they find out everything's okay, and nobody's stopping to ask them about disordered eating patterns. So it's important when they have that presentation to think about that. Let me see. So prevalence, 30 million Americans have an eating disorder. That's nearly 1 in 10. So it's a very common illness. Despite this, people aren't getting recognized, people aren't getting treatment. About 1 in 3 people with anorexia will get treatment. 1 in 3 people with binge eating disorder get care. And bulimia, it's much worse. It's about 6% of patients with bulimia actually access care. And then if you look at the people that are getting care, 80% of them won't get the level of care or the intensity of treatment, the duration of treatment that they need. So we're not getting the patients the help that they need. And this is a high-risk illness. It actually has the highest mortality rate, second only to opioid overdoses in terms of psychiatric illnesses. And unfortunately, people aren't spending money on research for eating disorders. It really pales in comparison to most other psychiatric illnesses. And so there's a lot of lobbying going on trying to get this recognized and trying to get some funding to support research. Social consequences are profound. These tend to be individuals that have a promising trajectory in life, but they fall off that trajectory. They a lot of times drop out of school. There's decreased rates of marriage and fertility. Talking about populations to screen, infertility clinics. If you go to an infertility clinic, you would be surprised at the number of people that meet criteria for an eating disorder. And so if you do the screening and you get people to get treatment for their eating disorder, and a lot of times gain weight, they can start having their periods, they can spontaneously get pregnant without any other interventions. And so it's important to think about that population as well. So lots of times it's really just stopping and including these type of questions in your interview, and then you can figure out how to help. High dependence on the healthcare system, about $67 billion a year spent in the healthcare for patients with eating disorders. So significantly high rates. It's, I think, next to schizophrenia in healthcare costs. The patients end up really being very dependent on the system to be able to survive. Study done looking long-term, 9 years after onset of anorexia nervosa, 35% of people have recovered. 2/3 have not. You go out 22 years, you're up to 65%. This is an important statistic to help patients have hope, because patients, I've treated patients now, I've been over 30 years, as Dr. Rockweisel told everybody. I've been in the field long enough to see people that I started treating 30 years ago that are actually now turning the corner and do well, and really starting to embrace life. So it can be done. There's always hope. And that's important, I think, within this patient population, to always be the bearer of hope for them. Bulimia nervosa, quicker response to treatment, 65% in that first 9 years. But then when you go out to year 22, you're still at 65%. The important thing to know here is the 65% at year 22 is not the same 65% as what was at year 9. It's an episodic illness with times of doing well and having relapse. And so people are varied in their response. Binge eating disorder, it's about 60%. The thing to know here is when they're talking about a positive outcome, and this is important for patients to know when you're working with them with binge eating disorder, that a positive outcome for them is to stop their binge eating and to normalize their eating pattern. Patients that are successful in doing that may possibly lose 10% of body weight. So if you started somebody at 350 pounds, they may lose 35 pounds, but then it plateaus and the weight loss stops. And if you keep them eating in a healthy way and you keep them to engage in an active lifestyle, they're going to be healthier. If they go back to restricting and dieting, that'll take them back to the binge eating disorder. They'll end up regaining weight and actually going higher. So you have to shift the goal for the patient away from weight loss more to healthy living. Move on to screening. The purpose of these slides is really to highlight, one, if you don't ask, patients don't tell, and two, if patients don't tell, they don't seek care. So in order to get patients treatment, you have to ask the question. The way to ask the question is to use the SCOFF. The SCOFF is a 5-question questionnaire. If people say yes to 2 or more of these questions, it's 100% sensitive for ruling in anorexia and bulimia. It's a little less than 80% specific, so you'll get some false positives. Now, the thing to know about the SCOFF, it was created prior to the DSM-5. So it's not catching binge eating disorder, it's not catching ARFID. And so you have to look outside of the SCOFF to identify that patient population. The nice thing is the APA is now making a very clear recommendation in their eating disorder guidelines that all initial psychiatric evaluations across the board include questions about eating disorders. So that's really, really important for people to be aware of, that, you know, we screen for psychosis, mood disorders, anxiety disorders, personality disorders, substance use. You're going to have to start asking about eating. And it's a basic question, and you'll be surprised. You'll really be shocked at the number of people who will endorse symptoms and actually open up because nobody asked them. And so for somebody to take the time to ask, they'll start talking. This is for ARFID assessment screening. The short ARFID screen is about 7 questions. The ones at the top are ARFID specific. And so just a way to try to incorporate that. Comorbidity, eating disorders are illnesses of comorbidity. You can see by this chart, 95% of patients with bulimia have another diagnosis. And 64% of them have 2 or more other diagnoses. So really significant in the comorbid range. And the comorbidity can actually impact the response to treatment. People use the eating disorder to treat the comorbidity oftentimes. So somebody with depression, they restrict, they lose weight, their mood goes up. Patients purge, they're able to concentrate and focus. And so the ADHD can be managed. I'm afraid to step too close. It's flashing a little bit. So the comorbidity serves a purpose. And most patients, when they come in for treatment, come in for the comorbid diagnosis, and you don't know the eating disorder exists because you haven't asked, and that keeps the comorbidity going. And so the patient's less likely to respond to care if you're not aware of the existing eating disorder. This shows, this slide is specific for ARFID. I need to put that up there, but shows the high rates of autism in this patient population, ADHD, and certainly anxiety really is a major driving factor for these patients. So I'm going to move into medical complications. On this slide, for anorexia, I really could have crossed out anorexia and put ARFID. The main thing to know is most of the medical complications associated with anorexia are also associated with ARFID. Bulimia, a whole nother set of medical complications. Okay. Anorexia affects the entire body, head to toe. All organ systems get impacted. The bone marrow, which produces your blood cells, is not getting the nutrients it needs to make blood cells. So the bone marrow dies off and it gets replaced with fatty tissue. So they end up anemic. When you first draw their blood work, they're probably dehydrated. So they look like they have a better blood count than they really do. When you get them hydrated, it's going to drop significantly. When people are starving themselves, the liver stops clearing cholesterol. So you retain cholesterol, and in the beginning of starvation phases, people end up actually with a high cholesterol level, which then freaks them out and they think they can't eat any more fat and it makes the illness worse. So you have to be able to explain that. But what happens over prolonged starvation is the cholesterol level will drop. Blood sugar, you store glucose in your liver in the form of glycogen. Glycogen, as you're starving yourself, glycogen gets broken down and the glucose gets released into the bloodstream to maintain normal blood glucose levels. The problem is eventually you run out of glycogen and your blood glucose level starts to drop. A lot of people with anorexia die in the middle of the night because they didn't have enough blood sugar to survive the night. So 4 a.m. actually is a common time for patients to end up not making it. Acute unit with patients at high risk, we actually will do 4 a.m. finger sticks to check the blood glucose level. Hormonal levels, we'll talk more about that. The phosphorus, you get phosphorus from food. So if you're not eating, you're going to end up with a low phosphorus level. And phosphorus is very important in the Krebs cycle. So you can't make ATP if you don't have phosphorus, and that's all sorts of problems from there. Liver function tests can go abnormal. You end up with euthyroid 6 syndrome. Basically, what's happening here is the body is wanting to conserve energy, so it shuts down the metabolism. The way it shuts down the metabolism is your thyroid T4 is driving your metabolism. So you don't want to produce T4, and you're converting T4 to reverse T3, which is the inactive form of T3. And so then you end up with a lower regular T3 level. The TSH does not go up in response to the lower T4. So that's what's sick euthyroid syndrome and the body's protective factors. Skin, your skin, you have dry skin because of the dehydration, brittle hair. The heart changes, GI disturbances. I'll go more into these. Osteopenia, fibrosis, hormonal changes, amenorrhea. So let's talk a little bit more about that. This is a picture of lanugo. It's the fine downy hair that appears on skin of individuals with anorexia. It provides a layer of insulation to keep the body warm. If you lose adipose tissue, which serves as the way to keep the body warm, the body produces this hair. Doesn't take much refeeding for that hair to actually fall off and to not be there anymore. Cardiac complications. You're losing muscle mass, right? You're losing muscle from your body. And so what happens here is the heart is a muscle, so it's losing muscle. The heart wall thins, the ejection fraction goes down. And in addition to that, the anatomy of the heart changes because of the thinning of the wall, and these patients end up with mitral valve prolapse. Every time the heart beats, it's burning calories. So your heart rate slows down, slows down, slows down. Patients frequently will have a heart rate in the 40s, and then it goes down even lower at night. And that's really protective. I actually worry more about somebody with anorexia who has a heart rate in the 70s than somebody who has a heart rate down in the 40s, because it's a way that they're protecting not burning calories. So that can be important to be aware of. Parents frequently have a hard time recognizing their child has an eating disorder, and they'll frequently talk, well, my kid's a great athlete. And so this is an athletic heart rate. Kids, great athletes don't have heart rates at 40. And what you do is you have them stand up and walk up a flight of stairs and then check their pulse, and it's through the roof because their heart is not conditioned. So that's a way to demonstrate it's not an athlete heart. The QT interval used to be thought because of starvation. It's more recognized now that it's because of the electrolyte disturbances, as well as the medications we're giving to help treat the GI complaints that can prolong the QT. Patients with ARFID tend not to get as bradycardic as patients with anorexia. The GI complaints, there's a lot of patients will present to GI clinics with functional dyspepsia or gastroparesis. See lots of patients that had been given a diagnosis of idiopathic gastroparesis, but they weren't asked about the eating disorder questions. But 55% of new patients referred for a workup of one of those two diagnoses had clinically significant symptoms of an eating disorder. 40% of them had significant ARFID symptoms, and 23% met full criteria for ARFID. 22% had some other eating disorder diagnosis, and the patients with ARFID tend to have higher rates of GI symptoms compared to the patients with anorexia nervosa. Superior mesenteric artery syndrome. Again, you're losing adipose tissue, and you can see here you have a fat pad that runs between the aorta and the superior mesenteric artery. And this is the duodenum that passes between those two arteries. If you're losing weight and you're losing your fat pad, the fat pad shrinks, and the superior mesenteric artery will clamp down on the duodenum and cause an obstruction. And that makes it quite painful for patients to eat. So what happens here is you need to drop an NG tube to decompress the stomach, and then get the tube past the compression so you can refeed the patient with the tube feeding, get them back to a healthier body weight so that fat pad gets restored and it lifts up. Historically, we used to use surgery. Now we do this more conservative approach. You can diagnose it with an upper GI and a barium swallow. The barium stops abruptly at the third end of the duodenum. It's very clear on an X-ray. Or you can do a CAT scan and they measure the angle between those two arteries. And when it gets below a certain level, then they have SMA syndrome. I talked about treatment. Osteoporosis. We store bone in our body. And we build our bone density up until the age of 30. After 30, it's all downhill. But up till age 20, by the time you're 20, you've stored 90% of your bone mass. So you think about eating disorders, early age onset, these people aren't getting the nutrition they need, so they're not building bone density. They end up being at a lifelong high risk for bone fractures. In terms of ARFID, we really basically haven't learned enough. There's not enough research to tell us about ARFID and what's going on. We do know these kids end up in shorter stature compared to a healthy reference database. So they're not growing, and it's related to their nutritional deficiency. The problem with ARFID compared to anorexia is a lot of times these kids go a long time not getting nutritional needs and not getting into treatment. And because of that, the buildup of the bone loss really accrues over years of their life before they even get into their teens, as opposed to a young girl in her early teens developing anorexia and it coming to light sooner. So there's more opportunity for intervention. Do it by a DEXA scan. The bone scan is the way to identify if somebody is meeting criteria for osteoporosis. Treatment, really the only thing that works is getting them weight restored. It's not going to get their bone back. It's not going to get their height back, but you can prevent progression of the illness. Amenorrhea, there's what's called hypothalamic amenorrhea. Now, in your adipose tissue is producing leptin. And leptin is a neuropeptide that actually can inform the brain when you're full. So when you eat, leptin gets released, your brain is informed that you've eaten enough and it's time to stop. Leptin also really will tell the hypothalamus that the body has enough adipose tissue for a woman to successfully carry a pregnancy to term. So the adipose tissue releases the leptin and it goes to the hypothalamus, and the hypothalamus responds by releasing gonadotropin-releasing hormone, which goes to the pituitary and releases FSH and LH, and that goes down to the ovaries to release estrogen. If you don't have enough adipose tissue on your body, you're not releasing the leptin, the hypothalamus is not releasing the gonadotropin-releasing hormone, and you have hypothalamic amenorrhea. So getting these people back up to a healthier body weight is the way to get them to start back to having their periods. Some studies have said they have to get to at least 90% of ideal body weight. Other research has shown they need to get to at least 5 pounds above the weight that they lost their period at in order to start menstruating again. So that can help you. And unfortunately, some women can get to that weight and maintain it and still not get their period back. And it seems like the system is stalled for whatever reason there. The main thing to know about amenorrhea and eating disorders is you need to help the woman if she needs birth control to have birth control, but birth control pills where she's getting a period is going to make the medical complications worse. She doesn't have the nutrients to replace the blood cells, and so the anemia and everything just gets worse and worse as you go along. Amenorrhea and ARFID. Most people with ARFID are premenarchal, so it's like 65% compared to 12% with anorexia nervosa. And the ones that are postmenarchal, 50% of them have irregular or absent menses. Nutritional deficiencies, the thiamine deficiency, worked with Dr. Woodbury on a case just recently, ended up with Wernicke's from the significant thiamine deficiency that occurred. And really, it's a high risk for these patients. Everybody thinks of alcoholics. You have to think of patients with eating disorders as well at risk for this. So let's move on to bulimia. It's okay, I'm gonna pick up my pace, okay? Physical signs of bulimia, calluses on the back of the hand, and the subconjunctival hemorrhages. I have some pictures of these, so this is Russell's sign. Gerald Russell wrote the description for bulimia nervosa way back when, and this is named after him. If you're inducing vomiting with your fingers and using your finger to get a gag reflex, when you do that, your teeth clamp down on your knuckle, and over time will cause a callus there. And that's what's called Russell sign. Sometimes you can tell if a patient's actively purging because they'll have a fresh cut on their knuckle. the pressure-inducing vomiting. There's a lot of pressure involved. So the capillaries on the face may burst, and you have petechiae across the face. If a capillary in the subconjunctiva bursts, then you end up with a hemorrhage there, as you can see with that in the picture. It takes about 2 years of consistent vomiting to take away the enamel from the teeth. And so when a patient's doing that, the acid's coming up, it's doing all sorts of problems, but it's taking the enamel off the teeth. And you can see you get this sort of translucent appearance through the teeth as they've lost their enamel. And what you want to do for them, it's not that you want to educate patients how to manage that, but you do want to do no harm. So brushing their teeth after purging is probably not the best advice, because the friction of the toothbrush against the teeth just makes the acid take more enamel off. You want to have them get used to using a fluoride rinse, and that can help neutralize the acidity in the mouth. Acute cyanosis, your parotids are making saliva. If you're binging and eating large amounts of food, the parotids have to make more saliva. You stop your binge eating, the parotids don't know that. They're still producing saliva, but they're not secreting it because you're not chewing with the binge. And so the parotids swell and it gets quite painful. You get this sort of classic chipmunk appearance here. You treat it with ibuprofen. You may want to give warm compresses and some lemon tarts, and that can help as well. Lab findings. Main thing to know here is that when you're purging, you're losing fluid, you get dehydrated. So what happens? The kidneys recognize you're dehydrated, so they want to retain fluid and not avoid as much. So they secrete renin, and then there's this renin-aldosterone system in your body, which I won't go through for the sake of time. But the aldosterone ends up coming back and telling the kidneys to retain sodium. So it retains sodium. Bicarb follows the sodium. So you end up with an elevated CO2 level. In exchange for holding on to sodium, the kidneys secrete potassium. And that's why you end up with a low potassium level. Chloride follows the potassium. So you lose potassium chloride, you retain sodium carbonate, and you have a metabolic alkalosis known as pseudo-Bartter syndrome. So that's important to know. And the reason this is important to know is because when a patient stops taking laxatives and they stop taking diuretics or they stop throwing up, the body doesn't know that they've stopped. So this renin-aldosterone system is still turned on. They're going to be retaining fluid, and then they retain large quantities of fluid. Can be really significant how much fluid gets kept in the body. They're third spacing that fluid, and it becomes quite painful and uncomfortable, and the way for them to solve it is to go back to their behaviors. You can use low doses of spironolactone if the patient is really struggling with this, but I only use spironolactone if they're in a higher level of care, because I don't want to give diuretics to somebody with an eating disorder to use at home. That's important, but the edema, and this is another reason I'll do another aside, which is IV fluids are really not the way to manage these patients. You want to really be very cautious with IV fluids. If you're going to use them slowly. I'd rather you drop an NG tube and put fluid in that way, or use the feeding. It's much better, the patient medically more stable. Their body has normalized and adapted to the starvation, and their body is functioning different than an average human. So you have to be aware of that when you're medically treating these patients. The elevated amylase is coming from the parotids, because the amylase comes from the pancreas and the parotids, but it's not pancreatitis. It's really from the parotids. So there's the metabolic alkalosis. Getting dehydrated, you get orthostatic. The acid coming up burns the esophagus, causes esophagitis. The pressure can push air out of the lungs and cause a pneumomediastinum. You can have a pneumothorax. Medical complications of binge eating disorder. Certainly, it's important to recognize that patients with binge eating disorder do tend to be at higher body weights, but patients that are at high body weights that don't have an eating disorder are much healthier than patients with the binge eating disorder. Couple points here. PCOS has a high comorbidity with binge eating disorder, and so does type 2 diabetes. So two patient populations to make sure you're screening for binge eating disorder. In terms of treatment, the main thing to know is these patients are very ambivalent about getting help. As I mentioned, treatment is scary to them because the eating disorder is serving a purpose in their life. It's helping them with their anxiety, with their depression, and they really develop an identity as the eating disorder, and they don't know who they'll be without the eating disorder. So it's a scary process. A lot of work of treatment is engaging these patients in the work of recovery, and you do a lot of work, you know the saying, you have to get comfortable with being uncomfortable. And so I always talk to patients that if they're feeling bad, they're in recovery. If they're feeling good, the eating disorder is alive and well. So you're trying to help them take the risk of feeling bad in the short run so they can feel better in the long run. Multidisciplinary treatment teams are really critical. Psychiatrists that understands eating disorder is really important to work with these patients. Medical management is critical. These patients need regular weigh-ins. Now, a lot of times, a PCP office, if they're doing the weigh-in, they don't know how to talk to the patient about the weight. So maybe have them do a blind weight there and tell you the weight, and the therapist or the psychiatrist should share the weight because patients are weighing themselves anyway. So you might as well do it when you can see how they react. Symptom management, this is critical. Patients always say, I want to understand my illness or I want to feel better and then I'll do better with my symptoms. And you have to highlight, it doesn't work that way. You know, you have to change your symptoms before the thoughts change. So you really have to work on the behaviors, and then eventually your thoughts will catch up to the behaviors. First line treatment for anorexia under 18 is family-based treatment. Parents are empowered to be the treatment team and do the refeeding. A lot of that is outpatient. If they come inpatient, a lot of work is done in preparing the parents to understand what they should be eating, what the child should be eating at home, and how can they manage the meal plan for them when they do come home. There's a transdiagnostic CBT for the treatment of eating disorders, and that's the main choice for people over 18. Bulimia, again, there's a bulimic form of FBT, which is helping the parents manage the binging and purging behaviors. The transdiagnostic approach to CBT for over 18. And binge eating disorder, everyone gets the transdiagnostic CBT. There is a guided self-help that they did a study which actually showed pretty promising results, which was really impressive. So there are some self-help books out there that can be useful. I think it's called Overcoming Overeating by Chris Fairburn. And that really actually has a lot of the psychoeducation that is in the transdiagnostic model. ARFID treatment studies, we just need more research. We really don't know exactly what's working. These are different behavioral therapies that have been in study. These are some manuals. Jenny Thomas wrote the CBT for ARFID, which is a wonderful book. And then there's the FBT model written by James Locke, and that's also very helpful. Medications. Anorexia nervosa, absolutely no FDA-approved medication for the treatment of anorexia. All these years, we still haven't come up with something to help with this patient population. SSRIs are frequently used to treat the comorbidity. There's some studies showing olanzapine can be helpful in providing for changing some of the cognitions and the body image distortion. Fluoxetine is the gold standard for bulimia, higher doses, 60 to 80 milligrams. Binge eating disorder, Vyvanse, the lisdexamfetamine, has the FDA approval. Really, short-term studies say it works. Long-term studies haven't really been completed, so we don't know for sure. In ARFID, the treatment here is, remember those three types I told you about. The people that just are indifferent about food and don't have an appetite, sometimes using appetite stimulating medication like cyproheptadine or mirtazapine can be very helpful. And that would target that group of people. The people that have the phobias, you may want to use the SSRIs. And then there's the olanzapine. Olanzapine can be used for the sensory group as well as for the phobia group and probably the indifferent group. So olanzapine actually is good. Now, the thing to know about olanzapine is you want to use low doses. You don't want the patients to get freaked out by side effects. So when I'm talking low doses, we're talking maybe 1.25 milligrams to start, maybe high dose of 2.5 milligrams. So you're using the lower doses. You use the olanzapine to get the person eating, getting them up to a healthier body weight, and then you're going to shift from olanzapine to the SSRI to treat the comorbid anxiety or whatever else is there. And that's the best way to manage that. Tim Brewerton did a lot of research on that, and that's probably the way to go right now until we get more studies. And this is just a, well, I'm really out of time, but this is just a quick review of what I just said. Step care approach, multiple levels of care. Indications for higher levels is if they're getting medically compromised, if they're still at low body weight, they're not responding to outpatient treatment, if they end up becoming acutely suicidal, if they have the comorbidity interfering with their response to treatment. Well, that was a whirlwind tour of eating disorders.
We have questions? Thank you so much, Dr. Carmen. It's a really helpful overview. I had two questions.
Yes.
The first one was about most of the medications that we prescribe as psychiatrists alter appetite and often alter weight. So I'm wondering if there's some thoughts about we might be iatrogenically triggering some of these problems in individuals because of the side effects of them. The other question I had was about, do you routinely screen for food insecurity? It's a common issue in patients that we serve. That impacts how you approach food disorders.
Yes, two great questions. So in terms of the side effect of weight gain from medication, it obviously can happen and does happen. And a lot of times I see patients that's how their eating disorder got started. They gained weight from the medication and they tried to lose the weight. The number one risk factor for an eating disorder is dieting. So the worst thing you can do for someone that's gaining weight from medication is to tell them to lose weight or to try to diet or to try to watch what they're eating, because that sets them down the path of disordered eating. A significant percentage of patients dieting go into disordered eating, and then a percentage of them will develop a full-blown eating disorder. So really it's about working with them about the benefits of the medication versus the risk of the medication and whether or not they feel the benefit is outweighing, no pun intended, the weight gain. And then looking at, is there an alternative medication that can be used for these individuals if they're getting that side effect, or what else can you do? But telling them to lose weight is the worst thing to do. So absolutely is a problem. The second question,
Food insecurity.
food insecurity. Yes, it's really quite a problem for individuals, the food insecurity, and they end up having all sorts of disordered eating patterns, including binge eating disorder is a high risk for them. So in terms of working with that population, it's about helping them to obviously have adequate amounts of food available to them, and then working on changing the behaviors. Where are they hoarding the food? Where are they storing it? A lot of them will have food in their bedrooms and things along those lines. So really, if they're an adolescent, helping the parents to do environmental engineering, where you're creating a more healthy home environment that's going to support normalized eating. So my thoughts about that. Okay. Yes, thanks.
So for kids or adults, they start on olanzapine. They start on olanzapine for treatment of overrestricted eating disorders. Can you talk? I only see them inpatient, right? So I put them on olanzapine and then I send them to you.
Yes.
Can you talk about what the course is for maintaining olanzapine, people are not working after kind of long term with people that are started on antipsychotics?
So a lot of times for these patients, like I was saying, like with ARFID, you get them to a healthy body weight, and then you introduce an SSRI, and you can back off the olanzapine. Now, I've seen enough patients, though, to know that that's not always working. Like a lot of times you start backing off the olanzapine, and they start obsessing and start feeling more fat and needing to lose weight and going back to the eating disorder. If they have anorexia or ARFID, the other phobia starts getting worse and things along those lines. So it's not always a great path, but that is the recommended path. And to try to leave the olanzapine on for as short a period of time as possible. Although that being said, I've had patients on it for years now and they're stable. The trick is to try to find the lowest dose that's working. Mm-hmm. Yes.
Thank you for this talk. Eating disorders are kind of diagnosed in all the media for Ozempic and other GLP-1 talk about how that is.
Okay, so the question was basically, how does Ozempic and other weight loss drugs fit into the eating disorder world? Is that a fair reframe?
At least not.
Yes. So it never ceases to amaze me when you recommend an antidepressant, how many questions and how much resistance you get around giving a medication to somebody to help them with their depression or their anxiety. Tell somebody that this medication is going to help them lose weight. They don't have one question about it. They're going to sign up for it and be the first to take it, and they'll inject themselves 4 times a day if it's required. And I think that's a sign of our society and our culture and where we're at. It's a problem because people don't consider the risks. And I think I worry about these medications out there and patients using them, that there's probably lots of unforeseen side effects. Recently, Ozempic was found to have ileus, right, as a side effect that people weren't aware of. And what else is down the road? I mean, when you get to my age, you remember things like fen-phen, and when fen-phen was out there and it was all the rage and all the medical complications from fen-phen, the body is designed for preservation. So the body is going to do what it needs to do to make sure that it's preserved and it protects itself. So most of these medications that are weight loss drugs are affecting maybe 1, if you're lucky, maybe 2 pathways in the body to support weight loss. The body has 100 pathways to support weight. So those other pathways kick into gear and they're going to override the medication. So I don't think long-term this is a solution. Also with Ozempic, my understanding is that there's rebound weight gain when patients stop the drug. So what are you doing? You're looking to live your life on Ozempic to support a lower body weight. It's really, really problematic. And it also feeds into the development of eating disorders. Again, no pun intended. Yes.
The first is the mortality rate in anorexia. Is there a sense of what percentage of that is due to suicide versus medical consequences of being malnourished?
It's a great question. About 50-50. So 50% of deaths are from the medical complications, maybe a little higher, and then almost about 50% are from suicide. Patients with anorexia actually have one of the highest rates of completed suicides. So when they make an attempt, I don't know if it's their perfectionism or what, but they are usually successful. So it's really serious when a patient with anorexia is telling you they're going to kill themselves. Not that it's never not serious, but patients with bulimia tend to have significantly many more attempts than the average patient. Maybe not as many successful, but multiple attempts, putting them at risk for successful completion.
The other question is about ARFID and thinking about some patients that I have who sort of exhibit, decreased intake of nutrients, but it tends to be more from like an obsessive, disorganized, like, oh, well, I need to get my calories in this way, so I want Ensure, or I'm getting my, I'm getting all my vitamins because I'm drinking coffee that's made out of mushrooms or something like that, and would that sort of like restrictive eating fall under ARFID?
So again, you want to look at, is there a body image concern? And so if there's a body image concern, then it would fall more into the anorexia side. If it's more, well, it's hard to know, like it's I don't think the jury's in for this gray zone. Like when they came out in the DSM-5 and they had ARFID, ARFID was here, anorexia was here, and no gray zone. And I think we're seeing more and more as we're looking at this illness, it's been 10 years now, that there are people with ARFID that over time start developing body image concerns. And how are we going to diagnose that group? So are they going to be ARFID with a body image, like a subtype there? Are they going to be anorexia with a sensory issue? Or, I don't know that the diagnostic work has been completed there in terms of how to do it. And I lost the point of your question. I'm sorry.
I'm thinking too that lots of times I think people think, even if we do think about extreme, like, people who are like extremely into paleo or something like that, the goal isn't necessarily like body image, but it may be like wellness.
So there's a category that's out there that's not in the DSM-5. It's been around a long time. It's called orthorexia nervosa. And it's people that are, for health reasons, pursuing eating patterns that do result in significant weight loss. So orthorexia, a lot of people that have been in the field for years and years think it truly is a variant of anorexia nervosa and falls into that category as opposed to into ARFID. And a lot of times when you take somebody with orthorexia and you start getting them to eat more food and gain weight, the body image concern starts surfacing. I forget, there was a study several years ago looking at vegans, and the number of vegans who chose to become vegan with weight loss is one of the reasons, not the only reason, but one of the reasons, was actually pretty high. So body image does tend to play a role. Yes.
Last question.
Last question.
Last question formally. I'm going to hear some time.
I'm happy to stay around.
Yes, so we'll take one more question. And before we take that final question, I just want to remind, if everyone can get CEUs if you fill out the evaluation. So we'll get those evaluations to people here online. You have them in the chat. And then for all the MDs, to make sure that you fill out the form at the beginning of the year so you get credit at the end of the year. So we will take one more question. And then for those of you who have more questions, Dr. Crawford will be happy to stay around and we'll take it from there. Go ahead.
Since there's such a high prevalence of eating disorders in gastroenterology clinics and fertility clinics, what kind of opportunities are out there that there's like education for these types of practitioners or more integrated care like within these fields to catch more people?
So asking about the OB practices and gastroenterology practices and how do we integrate mental health care for those populations given the frequency of eating disorders that can be found in them. It's a great question. I think the first thing is, when we're screening patients coming into health clinics nowadays, we do have to incorporate some form of eating disorder screening to try to identify this patient population. A lot of it is trying to also provide education to those doctors because the number of OBGYNs who say that they don't treat eating disorders is, I'm forgetting the statistic, but it's really high. They don't think they treat them. They obviously do, but they're not aware of it. And so you have to make the provider conscious of it. And, like throughout the course of a pregnancy, the focus that some OBs have on weight is not helpful in many ways. It's problematic. So, and really stimulates the most common time for a woman to, if she had an eating disorder, to relapse is postpartum. So it really is a high risk time. And I think what we need to do is really try to partner with the medical departments in the hospital. I think certainly, my contact has been with Dr. Woodbury. She really is building a bridge and helping to educate the other providers about this. And the more education we do, the better it is. I try to get to GI grand rounds and OB grand rounds and try to make people aware. I think that's what we need to do.
Thank you.